That we call it Dr. Mona to make it simple.
Exactly. That's my name anyway. It's fine.
Is that
Dr. Mona
all right?
actually was in the heart of COVID-19 when COVID-19 just came out in the month of February, March in New York City, in the place where that was the epicenter of the virus. And she worked actually in Kings County, downstate, and the place that already had high numbers, high, a lot of patients already. Then those patients were the patients that were high risk, and she was working with them in the emergency room. She was like the front of the frontliners. So, so please,
Infantry.
Dr. Mona, can you,
Infantry.
yeah, can you please share your experience during that time,
Oh my
the
gosh.
time when we had little understanding of the virus?
Right. I mean, listen, there's literally no explaining how this went down. Like, we didn't have a lot of forewarning about what was going on. We knew pretty much everything that we knew in the hospital was what everybody else knew, right? Like everybody was saying, oh, this is going to be like the flu. This is going to be like that. That's how we were. So I remember like being on shift like mid-March. Actually, one of my girlfriends had a birthday. I think her birthday is like March 20 something. I went for dinner with her right before work and I went to work. And I remember that day they were saying that was our last that was when they were closing outdoor, like closing all the restaurants. But we were in the hospital just walking in like a regular person. I didn't have a mask on. I didn't have gloves on. I mean, gloves on, obviously, with like patients, but we didn't have masks or anything. And then, as the patients started, and usually around that time, we didn't know. So patients were coming to the hospital asking for COVID tests. We didn't have COVID tests. So people thought we were trying to not test them, but we didn't have them, and the guidelines were saying only to test people that were either super symptomatic or being admitted. And most people that were presenting early were most people that were just anxious or had some kind of symptom that wasn't real, or maybe early symptoms. So it was crazy. Then when we started seeing the really sick patients, the CDC and the WHO hadn't really given us a lot of guidance on what we were supposed to be treating. So we were treating it like we were treating influenza. And if you guys remember, influenza, there's no antibiotics, there's nothing like that for influenza, right? So we just treat symptomatically. And we tried to do that. But then we started seeing pneumonias that look like when the person's entire lung, multifocal pneumonias, and the person would just be sitting up. And I remember exclaiming to one of my friends, like, I don't remember, like, multifocal pneumonia was an automatic admission to us. You guys remember from the ED. We're like, hey, MAR, listen, multifocal pneumonia, automatic admission. But that's when a lot of the patients started coming in with low saturations. We were just giving them oxygen and seeing how they did. And some patients would have multifocal pneumonias, like the really bad ones, and they looked fine. And we had to discharge them because we didn't have space in the hospitals. Then, we started running out of oxygen. We started running out of, and we were now using antibiotics that, it would be like, you look at the doctor next to you like, hey, what are you doing? And somebody would be like, I don't know, but let's just give them big gun antibiotics. And that's what we would do. We started getting guidelines from like our own hospitals. I worked at 2 different hospitals. I worked at Brookdale as well as SUNY Downstate. And, would get guidance from like our infectious diseases. And they would literally just kind of going by their own experiences and just giving us, okay, use these large spectrum and broad spectrum antibiotics, and we'll try that, but we'd notice that the patients wouldn't get better, or the ones that would get better anyway, and the ones that got worse. It just got super terrible because, like if you remember how the emergency room in Kings County was, we were already pretty full anyway, and we started having double rows in the ED. And these are really sick patients that need eyeballs on them all the time. And you remember the nurse volumes are 1 to maybe 7 on a good day at a lot of these hospitals. But during COVID, each nurse might have about 15, and these are really sick patients. So as you can imagine, as a doctor, you're running around seeing patients, the nurse is running around trying to medicate all the patients, we're running out of stuff, the oxygen is running out. And that's kind of when I started making the videos, like, guys, this is like really serious, we are young and healthy people, and we thought we were okay, but we started seeing really healthy people just show up. And a lot of it, my personal comments was that I think, our people don't usually go to the hospital. We think I'm healthy, I don't need to go. I'm not sick, so everything's fine. And COVID was that test of your immune system, you know? So, I mean, not to keep talking, but that was like the first experience for me. It was traumatic. And, you know, I do global health, I do international emergency medicine. So I travel, you know, in third world countries, and I work in places with very, very limited resources compared to us. And it felt like I was working in some of those African and Asian countries in America. So it was really tough.
Wow. Wow. That's that is that's a very, very scary experience there, Mona. But kudos to you, you know, um, to be able to, you know, hang in there and do what you can. I think that's what the calling of medicine is certainly about, and you know, we're very appreciative of your experience there. Not all of us can certainly say we've had such experience, so I so much admire that. So Mona, if you don't mind, I will maybe put you on the spot, so to speak. Okay.
Okay.
Sometimes the healer becomes the patient, right? And I got to learn that you yourself had a personal experience with this disease. Can you talk a little bit about that?
I mean, yeah, for sure. I mean, I had very mild symptoms, you know, and when I say mild, I mean really compared to all the other patients that were, you know, really critical and doing a lot worse than I was. You know, we were really, I mean, we were working a lot. Sometimes, you know, you knew you had your one day off coming, and then all the other doctors started getting sick. So you would get called into work, and I just thought I was exhausted. I was tired all the time. And I just thought, you know, I'm just tired. Then I started having some abdominal pain that I was like, oh my gosh, I think I have appendicitis or diverticulitis or something so bad that I called a friend of mine who had an urgent care, and I asked her to come to her clinic so she could order me a CAT scan, examine me and order me a CAT scan. You know, I had rebound guarding and everything, and she ordered the CAT scan. But then when I called the center to get the CT, you know, they asked me about my symptoms. I happened to have like very mild fever, but I didn't think anything of it. I mean, I had like a little bit of cough, nothing special. Then one day I was at work and I just felt terrible, like the worst headache I've ever had. And one of the nurses was like, Doc, like, are you sure you should really just get tested because, you know, you've been complaining about this headache and this abdominal pain for a week now, you should get tested. So I got tested, and you remember, you guys, our COVID tests weren't coming back for about 3 days. So I go
Right.
home, I'm just waiting for this test, and I keep going to work, right? Um, and then one day I was trying to make dinner to go to work, and I burned something, and I noticed I couldn't smell. Like I almost burnt myself up in my apartment, and I couldn't smell. I was like, oh my gosh, I think I have COVID. And that was when we only started realizing that anosmia, loss of smell and loss of taste, was one of the symptoms. And literally the day after I realized I didn't have the sense of smell, that's when my COVID test came back. And you know, like everybody was calling it the virus. Everybody was super scared about having it, and really worried, like, you know, am I going to spread it to other people? But for us as healthcare, as long as you didn't have a fever, our protocol was you come to work. So we were going to work. But then when I had the results back, you know, they told us I had to stay at home and just make sure I had about 7 days to make sure I didn't have a fever. And the first night I had the results back, like any human being, I was like, oh my gosh, what's going to happen? I had a fever that night and I couldn't sleep. Like I was so afraid, I was anxious. I sent a text message to my mom, like, hey mom, like, I'm not trying to scare you, but you know, my test came back positive. I feel okay, but you know, I don't know, because we'd watched all of these patients look really well and then just crump, you know, overnight. So I was a little anxious, even though I was probably not the patient to get unwell. And then, you know, the next couple of days were just like regular days. I just took Tylenol and Motrin to keep my fever down and came to work the next couple of days. I mean, the fatigue lasted a really long time. My GI system never recovered. I lost a lot of weight, actually, it was good. But you know, I think the most common symptom for most of like the healthcare providers was we were really fatigued and we had no idea why. We just thought we were working a lot, but a lot of us were exposed early on and recovered super early. So that was my experience, and I shared it with everybody just because I was so scared. And then I was like, oh, it's okay as long as, you know, I mean, I was healthy. I know my health status, so I wasn't too worried.
Yeah, thank you for sharing this, Mona. Yeah, so sometimes is uh, when you go to the other side, so you get to experience what your patient's going through.
Right.
I think it's a different feeling. Dr. Bayani is here with us. Dr. Bayani is an assistant professor and he's an ID specialist in Texas. Hey, how you doing, Nick?
Oh, good. How are you doing? Thank you so much, Mark, and thank you, Mona Lisa.
Hello,
It was a
Nick.
great story to hear. Hello, Will. And sorry I joined late.
That's okay, man.
No worries.
We're still waiting for Dr. Peluso. He's in a procedure right now, so he's coming later.
Looks like he's doing a thoracentesis or putting a chest tube in there.
Yeah. Nick, we would like to know, we just spoke to Mona about her experience in New York City when the virus just first hit. I mean, at least when we first knew about the virus. So we'd like to know your experience as well from an ID specialist standpoint, because you provide a lot of support to us in the front line in terms of guidance and guidelines and how to treat this. So I know Texas recently went through a surge. So just tell us a little bit about your experience.
So I think, first of all, I commend the frontline healthcare workers in New York, for the work they did to take care of the patients and really sacrifice their well-being, family, to take care of this. And, I'll be honest with you, we had a late surge, but we learned a lot from the folks in New York City. And I can tell you that the big difference between the surge in New York City and the surge over here that we had for about 6 weeks was that at least there were guidelines on testing, treatment. There was availability of remdesivir. There was availability of convalescent plasma. I could imagine in April and May, what New York went through, it's sort of like, we use the analogy of like a tornado coming right through your town without any forecast, without any warning. And I think that's what really overwhelmed, New York City. Here, we were being in North Texas and Dallas, we were not as overwhelmed as, South Texas, like Houston, El Paso, because a lot of those southwestern cities in Texas, they're on the border of Mexico and Texas, some of the poorest areas in the United States. And I would say, based on what I've heard from and talking to folks down there, that what they were facing was as dire as what was happening in New York City. There were doctors in Houston, El Paso, even San Antonio, who were really falling, ill, and some of them did succumb to the virus. Here, my experience, so first of all, I'm in Northwest Fort Worth, and, we have 100 bed community hospital. I'll tell you, the most COVIDs I took care of in one day, we had about, out of 100 beds, maybe about 1/3 of the hospital was full of COVIDs at one point. We're very fortunate that, our mortality was less than 1%. And the reason being the availability of resources. Bottom line here is starting the remdesivir, the IL-6 inhibitor tocilizumab, the convalescent plasma as soon as possible. And the patient outcomes did improve. Of course, a lot of our patients that we have seen, the younger folks, because the population that we serve is, the median age is anywhere between 35 to 50. And most of the folks that we saw who were in their mid 40s, overweight, they tend to have a prolonged course than some of the nursing home patients we had who had COVID. They would come into the hospital and they'd be out of the hospital within 3 days. So definitely, as we have read in the literature, obesity and comorbidities plays a big role in, treating this virus.
So Nick, thank you for that. That's it's good to get all these different perspectives, right? So that's awesome. And since you've mentioned a couple of things in with regards to treatments, so maybe I can ask you guys about treatment protocols. So how Can you give us a little bit of the history and how that, has changed over time, over the last maybe 6 months or so? Maybe we can
Sure.
start with you, Nick.
So one of my other job titles, I do administrative work too. I'm actually an infectious disease advisor and epidemiologist for a large health system here in North Texas, one of the largest faith-based nonprofit health organizations in the country, called Texas Health Resources. And I'll tell you, in April, when we started rolling out these treatment algorithms, I'll tell you, the first two drugs that were on the list was hydroxychloroquine and azithromycin. And anybody who comes in, they're asymptomatic, give them their hydroxychloroquine, azithro. It was on the order set in Epic. And then when we found out that, this is, first of all, the FDA said they've halted all clinical trials and everything. And then overnight, I'm talking to my system clinical pharmacist. Hey, before we meet with the ID medical directors, we need to get this off the algorithm, because nobody's recommending this. There's really no proven benefit. And I can vouch for that. I mean, I saw 2 patients who were on hydroxychloroquine for rheumatoid arthritis who came in with profound COVID illness. I mean, their O2 requirements are very high. So if hydroxychloroquine has some benefit, why didn't these people benefit? And as a matter of fact, they were getting a higher dose for their rheumatoid arthritis. So immediately we took that off. And our big challenge here was, when you give hydroxychloroquine and azithromycin, it seems like almost every other person's like on amiodarone.
Exactly.
We saw QTC prolongation.
Yep.
I mean, I had pharmacy call me up like, hey, do you really want to give this hydroxychloroquine and azithro? You better have a cardiologist or an EP specialist on standby. So I'll tell you that once we got that off, then and thank goodness for the recovery trial, gosh, dexamethasone became the first drug. Now, anybody who comes in with a chest X with gram glass opacities requiring O2 supplementation, then start them off on Decadron. We give vitamin C, we give zinc, and of course, low molecular weight heparin. And based on our experiences, I've never seen in 1 week 3 pulmonary embolisms due to COVID-19. So we are given anticoagulation judiciously. Of course, if there's a contraindication, somebody's like had a hemorrhagic stroke or a head bleed, or it's a demented patient who's a fall risk, then of course we kind of weigh the pros and cons. And of course we give them anticoagulation while they're in the hospital, but then upon discharge, we are very careful about giving it to them unless their D-dimers are through the roof. So we start off with the dexamethasone, and then if the person has an elevated ferritin, their O2 requirements are elevated, we'll jump in and give them a dose of the IL-6 inhibitor, the tocilizumab. And also we have a healthy supply of remdesivir in our health system, and we have guidance around that because the FDA a couple of weeks ago just came out and said, hey, anybody who's hospitalized, they will get remdesivir.
Yeah.
But we need to have some clinical criteria, because we've had a couple of asymptomatic patients who have come in for other reasons. COVID was not their reason they were here. And next thing you know, would that person be getting remdesivir? They're not on 3 liters of oxygen. They're saturating 98% on room air. So we have to have some clinical guidance. And then of course we got the convalescent plasma. And we have realized that if you give it within 7 days of the onset of symptoms, not from the date of testing, but onset of symptoms, the outcomes are much better. And we do have checks and balances. Our system administration, our leadership is very assertive about this. They're keeping tabs on each of the hospitals. Okay, how much remdesivir is being used? Who's the prescribing physician? And mainly the remdesivir is restricted to the ID physician, and also convalescent plasma, because you do not want to exhaust your valuable resources.
Yep. Thank you so much, Nick. We have Dr. Peluso with us. He's an intensivist in Oklahoma. he dealt with the very sick patients. He was a little bit late because he just had an emergency to do a procedure. So Nick, uh, question for you. We asked everyone what was their experience, their general experience when this thing first hit. So we have the same question for you. What was your experience, especially you were dealing with the very sick patient in ICU? Just tell us a little bit about it. We saw your Facebook post. They were very moving. So tell us a little bit about
Can I cuss?
it. It's up to you.
No, it was pretty terrible. I mean, all in all, it's kind of a helpless feeling. You kind of, when we got hit with it at first, I think obviously we didn't know what to do with it, just like anybody else. I think that we had a couple of cases right off the bat that just did very terribly on the ventilator. I mean, we had a number of cases because, back then we were doing all sorts of different vent settings with high PEEP and trying to almost run them as ARDSnet, which they did not like at all. I got a lot of chest tube practice, which I didn't really want. Still get some of that because they're so friable and they end up with barotrauma anyway, regardless of what, vent settings we do. But it was kind of a struggle just to kind of figure out how to even approach it. And then we were running with the initial hydroxychloroquine, Izithro, not zinc, but that combination when people came in, I noticed the same thing. A lot of QT prolongation, just being there with COVID. There wasn't really a rhyme or reason, why they had QT prolongation. They weren't on any meds that would prolong their QTs. And then we end up seeing that get worse. Sometimes people arresting just based off of the initial protocol we were using. So that kind of extinguished very quickly. I think it was only a matter of maybe 2 weeks that we were using it, and we kind of abandoned it. I think our facility is still working with Mayo with their trials. So we're just an extended arm of that, which is the convalescent plasma and the remdesivir. Trying to think if we're still using the other, like the IL-6, like you're mentioning a minute ago, and I don't see much of that. But yeah, it was just a very kind of defeating feeling to not be able to actually even treat people. I mean, it wasn't so much that my treatments weren't working, it was that we literally have no idea how to treat it. Just kind of steamrolled us.
It was the story for everybody.
Yeah, definitely.
Mhm.
Welcome,
so,
Nick. Thank you for that. This is Wally here.
Hey,
Hello.
how you doing?
Good. Thank you. So let me ask you guys about, we're just going to change gear a little bit. So there's been a lot of reports of racial and ethnic disparities, as far as cases of COVID-19 and deaths, are concerned. So maybe you guys can share, your observations within your communities, with us. Can we start with you, Mona?
Okay, so, I don't know that COVID itself was choosing, my experience, I mean, I work in safety net hospitals. I don't work at any other hospital. And we were hit pretty hard by COVID. So in my personal experience, I mean, I don't know, like I never worked at like Columbia or Cornell or somewhere else with a lot more resources or a different patient population than we did. But my patient population is, you guys remember, mostly diasporan, Caribbean, African, and African American, mostly within East Flatbush and East New York region. Like some of, so even when you Google the zip code that our hospital sits in, it's a safety net hospital. There's a lot of like sort of inherent disparity within the community itself. The resources don't flow the same at, downstate hospitals as they do flow upstate hospitals. I think they tried to sort of fix it when they made SUNY Downstate one of the COVID centers for New York State, but it didn't really make a difference because we were already suffering. I mean, as far as disparities wise, I think it's something that's been going on for a really, really long time. And this was the thing that just shone the light on it. I think Nikhil was saying that, a lot of our obese patients didn't do very well. Like if you saw like an obese, it didn't even have to be morbid obesity. Obese patient walk in and their SAT is 92. You're like watching them like a hawk because you don't know what's going to happen. And you guys remember, like, you know, people used to joke around and say Flatbush healthy or flat, you know, flat, because that's the BMI in general in lower income communities is a little higher than most places. And we can sit here and talk about the different reasons why, you know, there's Popeyes on the street everywhere. It's harder to get, you know, really healthy food. So definitely the health disparities played a major issue. Our hospitals also weren't as stocked as other places. I mean, I think we were definitely hit earlier, but I think when I talked to some of my colleagues that, I mean, we didn't have PPE like across the board, but other places had resources or people in place to sort of get it a little faster than other places. So we didn't have that. So you come into a situation now where maybe the doctors figured out a way to get PPE for ourselves, but our nurses don't, and they're still afraid. And these are the people that we need to go in and help the patients. So it was just like a gamoosh of like, it's my favorite word, of like just all of the terrible things that could happen to low income, you know, I don't want to, you know, it's not like a, you know, racial conversation, but it was mostly like Black and Hispanic people that did not do well. And the hospitals that I work in, those are the patients that they take care of. And therefore, like, our mortalities were really, really high. And it was just like a really stressful environment. We didn't have resources and our patients didn't do well. So it was just like a cluster of everything. I was trying not to cuss like Nick.
Thank you, Mona. I appreciate that. And Nikhil, what about you? You want to share some thoughts on that?
Yeah, you know, definitely. I mean, I agree that, you know, one, I think it just really comes down to the population you serve. And of course, our demographics is totally different. I mean, the hospital that I serve, of course, you know, has folks of, you know, that who are mostly young, middle class, upper middle class. Even some of the older population don't have as many comorbidities, but some of the folks who did come in the hospital, like anytime, you know, as Mona Lisa said, if I see an obese person, you know, I'm like, great, this is not going to be I mean, you already know whoever comes in through the front door, what you're going to expect, even if I give the remdesivir, the plasma, you know, and still they're requiring high flow nasal cannula oxygen. We're doing everything we can to prevent them from getting on the ventilator. And, you know, true story, I was on a weekend call. I saw a 468-year-old, 31-year-old gentleman, COVID positive. On a Saturday afternoon, he was streaming movies in his hospital room, looking like, hey, when can I go home, doc? Maybe tomorrow. You're on 2 liters. You're looking great. You're 98%. Then on Sunday, I get a distress phone call from the hospitalist who goes, hey, this guy's moving to the ICU. His O2 requirements all suddenly went up to 10 to 15 liters. And then I come in Monday morning, he's already on the ventilator. You know, keep in mind, this is a 468-pound dude on the ventilator. He's like on FiO2 of 80, PEEP of 12. Can't put him in a rotoprone bed. So we had to transfer him to a level 1 center, which is in Plano, that was doing ECMO. And the gentleman was transferred, a 31-year-old getting ECMO. Then on the other hand, I have a 92-year-old woman who I call the trooper, who's like the Harrison's textbook of internal medicine. She has a history of colon cancer, cervical cancer, bilateral nephrostomy tubes, multi-drug resistant gram-negative sepsis. I'm not making this up. This is true. She's on dialysis, 92-year-old, had COVID. I go see her in a post-acute care facility, and she goes, what's going on, doc? How do I look? I'm like, you survived COVID on top of your history of colon and cervical cancer, 92-year-old. And she's still a full code. So the virus, it doesn't pick and choose who wants to get it. I think a lot of it just comes up with the genetic, I mean, with the makeup of the person, the ethnicity part. You know, I'll be honest, maybe some of the Latinos that we do see in our hospital might have a higher BMI than the other folks who come into the hospital. Could that be playing a role? Also, a lot of these folks who are uncontrolled diabetics, you know, have had issues, kidney disease, you know. So I don't know if the virus picks and chooses ethnicities, but definitely I think the underlying comorbidities plays a bigger role.
Right.
Thank you for that, Nick.
Detail too, I think, because like you mentioned that you were able to, you could call for remdesivir, you could call for a vent. We got to, I mean, and this might have just been because it was early for us and nobody had anything. I don't know. But I also just know that our resource situation at baseline is not, there's just some things that I just can't always call for, even considering that. So yeah, I agree. The comorbidities and a lot of other sort of things played a role, but I still feel that part of our communities, as far as like how the hospitals were actually set up in some of these safety nets, the resources also did play a big role. So if you're like that 90-year-old woman, definitely her genetics sounds like would have helped, but if she had been, I don't know, and maybe if she had been at my hospital, we ran out of oxygen and maybe she needed oxygen for 5 days. And we were now like, not rationing it, but it was running out to where like we had to find places to get it. And we didn't have capabilities to transfer anybody. There's definitely no one place in New York City that has ECMO. And even the ship that they sent to us, we couldn't transfer anybody there. So unless you were in Manhattan, those are the only patients that could be transferred to the ship. So it's like,
definitely resources, that plays also a factor in this too. I mean, definitely in South Texas compared to North Texas, they're resource poor. I mean, I'll be honest with you, we were accepting patients up here in our hospitals because I handle all the transfers around our health system. They were coming from one of the most impoverished counties in the United States is Hidalgo County. Most of the deaths that are reported in Texas due to COVID come from Hidalgo County. We were getting transfers from up there because there was not even an ICU bed or even a step down bed available unless you cross into Dallas. I mean, there were patients who were coming in here going, where am I?
Yep.
Yeah.
What's your experience
And,
in Oklahoma, Nick? Nicholas, what's
Yes.
your experience in Oklahoma?
Oh, well, Oklahoma,
Where are you down in Oklahoma? Where are you? In Oklahoma City?
no, Tulsa.
Okay, Tulsa.
also,
Yeah, so Oklahoma is a special state. Um, there's more lung disease. I actually spent a couple years in Eastern Kentucky in coal country, and I think the lung disease here is worse. Yeah, I think we have an inhaler on our state flag. So the amount of people we've had come in with horrible COPD to begin with, and I think that's a big part of why things have gone so badly in this state. It's just, anybody who's getting it that has any kind of history of COPD, whether it's controlled to a degree or they're on home oxygen, just not doing well at all. I'm very lucky that the facility that I work for, it's a tertiary facility. It's a major stroke center, trauma, everything else. But it's a community hospital essentially, but our PPE has been stocked to the brim since the beginning. They jumped on it immediately. And they've kept us very well stocked with everything. And all of the docs in the ICUs here all bought our own respirators way at the beginning. So we haven't gone through what other places have gone through, like epicenters like New York. And I think like you mentioned, even like Texas is going through. So I've been very lucky to be here, and actually think my facility and administration is doing a good job, which I don't say a lot. But yeah, I think when it comes to who we're seeing, I think that the confounder is the baseline lung disease in the state to begin with. I mean, we've had every ethnic population in here, and it's hard for me to discern who's doing well and who's not based off of their background, based off of Hispanic, Black, white, whatever. I've seen a pretty equal distribution in people not doing well, and even age. I mean, we've in Oklahoma or in Tulsa, we've had trying to think of how many, but we've had a number of 20-something-year-olds, 30-something-year-olds that have died of COVID that didn't have, you know, much of a background other than obesity. That's been kind of the big factor, like, you know, was mentioned. Someone walks through the door, you can kind of tell how they're going to do. And in reality, the people who have obesity, which is a lot of Oklahoma, have not done well at all.
I feel like that's reassuring.
Yeah.
Have everything sort of fixed, you know, it just means if everything is sorted out properly, it's not going to pick, well,
Yeah.
you know, people how they feel. So yeah, that's actually reassuring, because I didn't have that sort of background to understand that.
Yeah.
I think in my institution also we were pretty stuck in that. I don't think we ever had any issues with the PPEs, but of course we got hit later than in New York City. So I think
Well,
we
and
time.
to be fair, I'm speaking only from a standpoint of the ICU. Out on the floor, I think they've probably had some problems. They've also had some containment problems. You know, you have people out on the floor that you can't test every single person that comes through the door, and you might find out a week later that somebody was positive for COVID. They were just asymptomatic. They just popped positive.
Oh,
Yeah,
so we've been testing. So whenever anybody gets admitted, they
Yeah.
sit in the hot zone until we get a COVID test for them. That's interesting.
yeah. I wish that we could do this state has, I don't know if anybody's been following Oklahoma and our leadership, but it's been kind of a more of a grab a broom and sweep it under the rug than anything. It hasn't been very proactive at all. We had a lot of problems with getting reagent for testing for a period of time. It's much better now. We're able to get tests back in 2 hours, and pretty much anybody that comes into the ICU, I'm testing, period. Not pretty much anybody, really. I mean, they're all getting tested.
Yeah, usually get them when they're pretty sick. Anyway.
Yeah.
Um,
Yeah,
Well,
that's the other part of it. I'm getting them when they're doing terribly. So
in some place, well, that sounds luxurious to me.
yeah,
To
I'm
be
like
able
right
to
in the
test
middle.
everybody.
I'm like right in the middle of it. We can't test every patient, but I'm at least able to test who I want to test.
I think New York is doing a pretty good job with testing now because some of my family members work in healthcare system and also nursing homes, and they told me they almost getting tested, especially the one that work in nursing home. They're getting tested almost every week.
Right.
Wow.
Yes.
It's easy.
That's
So the governor, President Cuomo, like literally you can walk into urgent care. You can walk into City MD. You can walk into any place that calls itself a healthcare center and get a COVID test.
Yeah.
It might not come out, and it's free. It's not charging anybody's insurance. So there's no reason for anybody to not get tested. You can literally walk in and say, I need a COVID test, and you get it. I mean, we've also kind of gotten to the point where we're getting a lot of patients coming into the ED just for that. And sort of with the rest of the world starting to open up, especially tourist destinations, that's the most common chief complaint in the ED these days. I'm going to Jamaica, I need a COVID test.
Wow.
Wow.
All right, so I'm going to move you guys just so we can get a lot more questions in. I'm going to change the gear a little bit. So Nick, we're going to start. Nikhil, we're going to start with you here. So, you know, as the saying goes, necessity is the mother of all inventions, right? And COVID-19 has definitely led to a whole lot of different changes in a lot of places. So is there any particular innovation at all at your institutions that you guys would like to share with us, the public? Let's start with you, Nikhil.
Well, in terms of innovations, of course, I'll tell you, going back when the Mayo Clinic had their expanded access program for, you know, the convalescent plasma, we immediately signed up right off the bat, and then now now you have the emergency use authorization through the FDA, so that has become easy. I mean, one thing in terms of innovation, I mean, I would say that anybody who, you know, we have easy access to testing. We are hoping to look into something because we just found out that UT Southwestern, which is one of our affiliates of we're a large clinical integrated network with them. They're apparently doing studies with monoclonal antibodies. So yesterday when we had our ID medical director meeting, one of the ID specialists at Presbyterian Dallas, and I'm sure you guys know about Presbyterian Dallas because in 2014, that was the site of the Ebola patient in the United States. And they, let's put it this way, they are still somewhat recovering from that. And when I was talking to their medical director, she reached out to UT Southwestern and they said, yeah, we're not doing much convalescent plasma. The reason being, they are enrolling patients in studies for monoclonal antibody therapy, which is pretty impressive. And I think it's Regeneron that is developing that. And if those patients received convalescent plasma therapy, they are immediately excluded from the monoclonal antibody trial. So we eventually are trying to look at and see if we can get some of our patients enrolled in that, provided that UT Southwestern, gives us permission and we can get something together on an IRB level. But that would be something very interesting that, we're looking forward to. And one thing is that if the monoclonal antibodies do work, convalescent plasma might be obsolete.
Wow, that's
Yeah,
interesting.
I think in my institution we had the same issue too. We were trying to get monoclonal antibodies, so we had to make a decision between continue to do plasma or do that instead. So I think we were doing so good with the plasma. We continue to do plasma for now, but I think that's something we can always reconsider too.
Right.
Yeah. So what about you, Nick? Anything peculiar or special you guys are doing in Oklahoma that can be beneficial to the rest of us?
Well, not a whole lot different. I mean, we also put ourselves on the Mayo study at the very beginning as well, and we're kind of running with the plasma thing. I don't necessarily think that it's extremely effective. I think that time is going to tell, but I haven't seen that many cases that have done well with it. I mean, we've had some pretty dramatic turnarounds, but otherwise it's not been that impressive to me. We're sticking with it for now, as far as I know, until the other the monoclonal kind of takes off. And I don't even know how many facilities are using that right now, or going to be planning on using it. I'm sure that we'll probably fall in line with that pretty quickly, though. I mean, my facility's been pretty quick to adopt early on, things like convalescent plasma. So I'm sure that we'll end up going that route as well. From my end, there hasn't been a whole lot. I mean, most of the stuff that I'm dealing with is the ventilators and airways and stuff like that. And, just early on trying to make sure we had everything in order, running BiPAPs as ventilators, having kind of makeshift ventilators if we needed them. We never ran out. But in terms of, new things to kind of share with people, I don't really have anything exciting, unfortunately. I wish I did, but it just hasn't been that for us. So.
That's okay too. All right, Mona, anything at all?
I mean, I think I'm with Nick. It hasn't been, we were so busy scrambling that, I think maybe on our inpatient side, perhaps people came up with something. I know there's a lot of research going on. A lot of people sort of taking advantage of, so we have a little bit of a lull period now in kind of the cases. And this is when we kind of came up for air, and a lot of the research projects are coming up. I know during like the peak, most of things that were going on were sort of MacGyvering things together, using CPAP or BiPAP pieces for PEEP when we didn't have PEEP, or, things like that. But I don't think it's anything that, we remember them, we took pictures of it so we could remember and document it for the future in case we ever went through anything like this. But I think for the most part, anyone else that was prepared didn't have to figure out how to jerry-rig oxygen trees from one room to supply 3 patients in a hallway because you're running out of oxygen tanks,
Yeah.
So that's not really anything I want to show off about, but, those are the kind of things that we were doing.
Hey, okay, we're just gonna ask another medical questions. I think we'll go for you, Nicholas.
Mhm.
So in the beginning of the virus, ventilators had a lot of attentions, like people were trying to get vents, we have to get, but now there's not too much attention to vents anymore. What changed? And the second question is that, do you have any timing for tracheostomy when you come to COVID-19 patients?
Sorry, you broke up at the end of that.
Any timing for tracheostomy, for trach? If you want to put a trach
Oh,
for
for trach,
COVID-19.
got it.
Yeah.
Okay. Yeah, so I think the ventilator thing, I mean, yeah, like you said, it was kind of at the beginning, like everybody kind of, was scrambling and saying we need ventilators here or there, whatever. Now you can find them in resale shops, I think. But I think that the reason why you're not hearing that much about it now is we've gotten better at keeping people off of them. I mean, early intervention, early proning. I think that we started manually proning people the first week this thing happened. That was one of the things we started doing very, very early. Now we do it all the time. I mean, if anybody's requiring any oxygen above 4 liters, we're having them do, as someone put it online, tummy time, and trying to keep them off the ventilator as best we can. I mean, we're using heated high flow nasal cannula a lot more in these patients, and then early dexamethasone. And one of the big things that causes these people to desat and end up on BiPAPs or vents is these coughing fits they go into, and they dump their sats, and it takes them so long to recruit back. So I've actually been using lidocaine nebs a lot, and that seems to curb a lot of that. So I think it's a combination of a number of things keeping them off the ventilator, and we're just doing it a lot more systematically now, rather than, it seemed like back then we were doing it a lot more rare, just for really, really sick patients, but I think it was just too late at that time to keep them off the vent. Now we're just doing it a lot earlier. In terms of traking people, I think we're giving people a little more time. We're kind of going over the normal, the normal barrier that we would have to talk about doing a trach. Yeah, I mean, we're still traking quite a few people, but yeah, we've certainly extended the time frame that someone's on a vent just for this.
All right. Well, thank you for that, Nick. So Mona, let me ask you, obviously you being an emergency room physician, you don't always know what's coming in through the doors, right? So how are you able to mitigate some of the risk that, that comes with the virtual of your specialty? And if you may also comment on maybe some of the typical presentation of COVID-19 to the emergency room that you guys, might have dealt with.
Right. So it's kind of hard to mitigate something coming at you. But I mean, after we knew that we tried to put masks on patients, but these patients are tough. Like, they can barely breathe, Now imagine trying to put a mask over them as they're going through these coughing spells. It was tough. Even when we put them on BiPAP, sometimes I had to find the filters, which initially we were using the HEPA filters, which we later found out didn't even really work. So, it's tough. I mean, there was a time when FDNY actually made a protocol where they were no longer doing any non-traumatic cardiac arrests, CPRs. So that's something that I think helped us, that there were a lot of patients that were coming into the hospital getting CPR and sort of aerosolizing everything. And then more likely than not, if you're coming in getting CPR, you're likely going to die, you know what I mean, before we manage to do anything. So a lot of those patients stopped coming to the hospital. I remember going outside to meet COVID suspected patients, but this was before, there was a time when we're trying to isolate patients. And then by the second week of April, the whole emergency room was like an isolation room. So the only way you could really protect yourself was to wear, your PPE, and we were initially double masking, like the surgical mask. And when we had N95s, we did that, the face shields and the gowns. We later on got the PAPRs, which were great for our skin, But I mean, I like them better, but you know, you just wear the N95s. That's what we were doing. As far as like the most atypical cases, I think a lot of the patients we were seeing at the time were atypical. We just didn't know, you know. We've had, you know, patients, young patients come in with like strokes-like symptoms, and we would call code strokes for those patients. And then later I find out that they were COVID positive because we didn't know when we first saw them. We had, you know, code STEMIs, and those were hard because the cardiologists weren't trying to come to the hospital either, right? And then you have a STEMI, they go to the cath lab, and then later on we find out that they were actually COVID positive, and actually the cath was negative. So it was, I don't know, COVID induced ACS. So now all of those cardiologists are exposed. The most atypical one that like really sticks with my mind was a young guy, maybe like not, I mean, he was obese, but not like out there like what walk past him on the street and think, oh my gosh, that guy is huge. And maybe my, you know, my vision is a little colored, but you know, he comes in, new onset diabetes. And you know, this is a typical patient in Kings County, a young guy. His glucose was 500 and something. So I'm working him up with DKA, and he's like standing around, walking around, no big deal. And then all of a sudden he falls on the floor and starts seizing. You know, went into a seizure, came out of the seizure, actually was status. I gave him Ativan multiple times, ended up having to give him Versed. And then I'm telling, you know, trying to get a bed to intubate this guy because he just kept seizing and seizing and seizing. And after we intubated him, finally got the post intubation x-ray, and guess what? Ground glass, like COVID chest x-ray, like everybody that's taking care of COVID patients knows what this x-ray looks like. And this was early on too. So I was definitely not wearing a PAPR. I wasn't wearing like the respirator. I was wearing like a surgical mask as we intubated this patient. But I mean, when it happens, it happens. You know, sometimes you don't think about it. Like I need to do compressions. You know, we didn't think about, oh, I need to put my mask on and my gloves on and my PAPR on before I start doing compressions. But later on down the line, we started because, you know, we started getting colleagues that were dying and colleagues that were getting sick. And it was just like, is it worth it? So it was really tough. Like, we didn't know what, at some point, any presentation, didn't matter what you said you had, was COVID until proven otherwise.
So thank you for sharing this, Mona. Nikhil, I have a question about isolation. I think because of the fear factor associated with COVID-19, the isolation rules has been very all over the place. I know the CDC set out some guidelines for when to discontinue isolation. So what is your opinion on discontinued isolation in hospitalized patient, and also in patient that's been readmitted to the hospital from previous infection with positive tests?
Right. So based on those criteria, and I think the criteria are quite fitting, the reason being, you know, even if you have recovered from COVID, you still can be an asymptomatic shedder for at least up to 90 days. Now, does that mean you need to be in isolation? Probably not. So the way we broke this down, and we kind of put a little bit, I mean, we do follow what the CDC says, but we went ahead and added a little bit more guidance. So if anybody that has been, let's say, admitted to the hospital with COVID-19 and they have received steroids, remdesivir, tocilizumab, let's say 30 days later, they come into the hospital for some GI bleed, for example. We literally have said that if it's been more than 20 days, actually, let's put it this way. If you ever received any of those treatments, you need isolation if your readmission is within 20 days. But if it is somebody who came in perfectly healthy, they just came in because they, you know, let's say, for example, the patient I was talking about, somebody came in with abdominal pain, the doctor decided to do a COVID, they had acute cholecystitis, but their COVID test was positive. The person did not need steroids, nothing like that. They get readmitted again, let's say within those after 10 days, then they don't need to be isolated. But I can tell you right now, majority of our patients who do come back into the hospital, they would have to be in isolation if their admission is within those 20 days. After 20 days, no need to isolate. It has made it much easier. Of course, everything is at the clinician's discretion. If the clinician feels, you know what, I'm not convinced by this. So now, of course, you know, we have the luxury of sending off a PCR to our micro hub in Fort Worth, and we will have a PCR results within 24 hours. Keep them in isolation. But I think since the new updated guidance from the CDC has come out, it has streamlined a lot of our isolation protocols and has made it much easier, simple to follow. I mean, in the beginning, we had issues that, oh my gosh, you know, should we be wearing an N95, face mask, surgical mask? Well, you know, for most of our aerosol generating procedures, everybody's wearing an N95, irrespective. And what about those folks who are PUIs? Well, you're going to treat a PUI as a COVID until proven otherwise. So I think with the new isolation guidelines and all that, it has become a lot easier.
Thank you.
Yeah, thank you for that, Nikhil. So if I may ask all of you, I would like to give each one of you guys the opportunity to discuss this, because I think this is real important. You know, one of the unfortunate side effects, so to speak, of COVID-19 is the loss of frontline workers. Myself, Mark, and Mona all trained at SUNY Downstate, and I'm at least aware of 3 people, 2 nurses and 1 ICU physician who actually died from this disease in that particular institution. And obviously, there's a lot of emotional and psychological toll, as a result of that. So for those of you that are working in cities and maybe hospitals with high caseloads, can you maybe talk about how you're dealing with that, emotional, psychological aspect of it as physicians? Maybe we'll start with you, Mona.
I'm gonna say age before beauty, but okay. I guess, for us, SUNY Downstate is an academic center. So we had, all of the psychiatrists were waiting and ready. They were setting up, even before we started having colleagues dying, we had our psychiatry department, our colleagues, like co-residents and co-attendings, that were looking for ways that they could help out because they weren't actually working the front lines. So we had hotlines that they set up, especially after the physician up at Mount Sinai committed suicide. Definitely a lot of like the suicide hotlines for frontliners went up a lot. But these were things that were going on already. As far as like personal coping mechanisms, I mean, we're all physicians here. We know, how to self-soothe. We know how to self-soothe, So I particularly enjoy spending time with my family. And so COVID was really tough because you couldn't, right? You were so afraid that you were going to make everybody sick. So you kind of isolated and you were home alone a lot. So, I mean, I enjoy my social media time. So I started doing like some Instagram videos and posts and taking pictures of patients, or whenever I happen to be out in the street, if I see somebody wearing a mask, like those are things that just kind of made me feel like I was doing something more than just seeing patients at work. I've been reading a lot of like self-help books, which is something I never really did because I always felt like I was always outside interacting. But, I think COVID just sort of we needed to slow down. Like, I think 2020 is not that we needed COVID to happen, but I mean, I'm just one of those people that believe in things happen because they were supposed to, like it's the alchemy of life. And I think, I just try to find different avenues to sort of keep myself busy, try to find opportunities within the chaos. And that's sort of where I find my peace. Like I keep myself really busy so I don't have time to like really stop and wallow in it. So we'll see.
Got you. All right. Nick, what about you? Dr. Peluso.
Oh, me. Okay.
Yeah.
Yeah, I've been very lucky. We've had a couple of our docs in our group get sick and have to be quarantined, but they didn't get to the point to where they were in the hospital. I've had a few of my nurses in the ICU who ended up doing well. We've been very lucky to not have a lot of that here. But just reading the stories from elsewhere is heartbreaking. I mean, it's horrible to see that. The mental toll of just dealing with these, taking care of these patients and dealing with these cases and having, an iPad, that's on FaceTime showing family members, somebody who's on a ventilator, who's paralyzed, who's never coming off, and they're saying goodbye. I mean, that's a pretty hard thing to process. We're offered, things like helplines and even therapy to some degree. But I think the most effective thing has been how close my group is to begin with. We don't hold anything back. We talk about whatever with each other. So we've been able to kind of get a lot of stuff off our chests just with each other, not having to really involve anybody else. I can't speak for everybody in my group, but me personally, I typically will just kind of say whatever I'm going to say. And if I'm going through something, I have a few partners that I can depend on to sit there and put up with my crap and listen to me, talk about what I need to talk about. And then I throw stuff a lot, but it's one of those things where I think everybody's got their own little thing, how they deal with stuff. I mean, I don't have a real set thing. I mean, as I'm sure people have unfortunately seen, I write stuff that gets shared on Facebook, and I think for me, writing is a good way to get that stuff out. I don't leave it around for people to read most of the time, but that typically clears my head and makes me get to a better place. It's just a matter of seeing it on paper and reading it and realizing it's a reality, and we do have to deal with it, but we also have to kind of express how we're feeling rather than keep it inside and to the point we explode or whatever. So yeah, I mean, it's a day-to-day thing, and I think that's pretty much it.
Yeah. Thank you for that, Nick. And Nikhil, Dr. Bayani.
Sure.
So, and we're very fortunate that, I mean, some of the doctors on the medical staff, very few did get ill, but nobody was critically ill. Very fortunate, but echoing what, Dr. Peluso said, that, hearing the stories are coming out of New York and other cities, it really was, gut wrenching. And really that was just a moment of, humility, that we should be grateful and thankful of what we have and appreciate life. And it makes you value life more than ever, because you never know what can you be walking into tomorrow and what will happen to you, your family, and especially the patients we took care of. I mean, the folks that I saw in the ICU, I remember nurses walking in with a tablet, with a family member on the other end, and this is what it is. And the family members just going through what they're going through, because it could be a grandmother, mother, father, uncle, aunt, sibling. They're going to the hospital. Are we going to see them? I could imagine that's what's going through their mind. And I think that's the part that really got me. But I'll tell you, we have a pretty cohesive medical staff where I work at, and we will sit in the doctor's lounge at lunchtime and we will talk, and that's a stress relief. And then of course, social media, listening to music. It almost got to the point for the first couple of months, I could not watch any movie that causes an adrenaline rush. I literally was watching more stand-up comedies. I just could not take anything that is very stressful. So it really comes down to, just relaxing and coping mechanisms in getting through this.
Yeah.
I think, Wally, I think we have one question from Facebook.
Yeah, let me see here. This is from Yolette Leisure. She was I think this is probably for Nick. She was asking how effective was the use of prone positioning in the ICU.
For you, Nicholas.
Well, Nicholas, yes, Dr. Peluso.
For proning, I think it's been very effective. It's obviously patient to patient, and sometimes it just does not work, and sometimes it makes people even worse. But I think that recruitment by proning, whether it's fully prone or putting someone on their side for a period of time, overall has been extremely effective. We have access to rotoprone beds, but bringing them in, because like my current COVID unit that we have right now that's pretty much full. It's a completely negative pressure unit, so the whole 22 beds, it's just all when you go in, you're in full PPE. Bringing the rotoprones in there just didn't make sense to us. So we have the surgical spinal pillows for the faces that when we flip people, we put them on those. And so basically we're just manually proning people, and it's been extremely effective, especially early on.
Yeah, I was gonna say it worked for us for the less critical patients. I think my concern early on when we first saw the patient, we didn't know. The worry was, first of all, our nurse to patient ratio was crazy. So the concept of proning someone and this hypoxic patient, proning them and leaving them, and there may be no real eyeballs on that person for a while, was something that deterred us from doing it. But yeah, I mean, I think the healthier patients that came with like low sats that probably just needed some time to get better on their own, they did well for us. But the sick ones, man.
Yeah.
Do we have more questions from Facebook, Wally?
Let me see here. Somebody mentioned skin tears with manual proning, but I'm not sure if that's a question, but I suppose that can happen with proning.
Oh yeah, most definitely.
Most of them?
No, I say most definitely. I've
Most
seen
definitely.
that. We have a big elderly population, and it's always frustrating, and makes us anxious to have to try to prone them, because we you see that periodically.
Right.
But yeah, and I'll also echo, when someone's that sick, where they're paralyzed on a ventilator, yeah, proning them really hasn't been very effective, but early on, I think is the main focus now.
All right. So
I had another comment, actually, just thought about, just listening to just sort of how COVID panned out in Texas and then in Oklahoma, and just reflecting on what our experience was in New York. I don't know, like emotionally, like I think for me it was tough. Like I'm not going to talk about that, but think about how like my two colleagues here are saying they had tablets to show patients their family members. We didn't have that. Like a patient would be dying, the phones would be ringing off the hook, and you have one clerk to answer all the phones. Like there were patients, and our families are diasporan patients also, right? So their families are in Jamaica and Haiti and all of these places, and they're calling and they couldn't find anyone to talk to them, not because we didn't want to talk to them, but we were so busy. And something that really hurt my heart, like I was like, I am busting my tail all day long, was listening to some of those YouTube videos or even some of the CNN comments of some of the traveling nurses or traveling practitioners that came out to New York. And they said we were killing patients. That was like the most, like, guys, we were like scrambling. We were scrambling. And not once did I ever spend any time thinking about which patient am I going to let die or not die. That wasn't anything that any doctor ever thinks about. And I, really felt like that was, I don't know, it was just like people sitting in, ivory towers looking down on people that are really struggling, and you say those types of things. And I think it also added to some of the anxiety that a lot of our patients had, where they wouldn't come to the hospital because they were afraid that, if I go to the hospital, I'm going to die. Well, if you stay home, you're definitely going to die. There was a time when we only were getting the really sick COVID patients, but my worry was that we also were still having strokes. People were still having heart attacks. People were still throwing large, massive PEs and dying at home because they're so afraid of coming, just because there was so much like information out there by like people that were just saying whatever, and I think for me, and I'm really grateful, like Nick and Nick, we used our platform to sort of talk and clarify that. And that's, for me, was my therapy, was, dispelling a lot of that incorrect information, because it was just like people that didn't know what I saw videos of people saying, putting like head covers over themselves and boiling like some leaves and putting yourself. And then I watched a video of the man catch fire, and he was telling people that's how you prevent yourself from getting COVID. It's just like, yeah, I don't know. That's been, I can't imagine what it feels like for people that don't understand medicine when they're watching all of these videos like that. Wale, your auntie that made that video about hydroxychloroquine, or all these things that all of our leaders are saying. Like, it's so we're seeing so many anxious pediatric patients show up to the hospital, like anxiety in a 9-year-old. How do you treat that? How do you tell a kid that you're going to be okay if they're just worried because grandma and grandpa both died of COVID in this hospital, a few months ago, and now I'm here, I might be dying. So it's just, I don't know how we're going to recover, but it's a lot.
Guys, thank you guys for a great conversation. We actually learned a lot from different parts of the country, New York, Oklahoma, and Texas, and we see there's similarities of different things that we do, and also there's a big difference depending on where the location and the different resources that available. Let's finish with this. I think I would like each of you guys, what is your advice for the general public? I think there's a lot, just like Mona was explaining, there's a lot of things out there. There's a lot of conspiracy out there. So what is your advice for the general public?
So I can answer that first, because echoing what Mona Lisa said, and I'm going to finish off what she said. And, pardon me if I take plenty of time here, because we had a couple of incidents. First of all, I want to say a dear friend of mine, she was an ICU nurse here in Arlington, Texas, who took on a traveling nurse position, and she came to New York City, and I'm not kidding. She said, I'm going to stay here until my job is done and when the patients are taken care of. When she came back here, she forged a new relationship, and she literally said it was probably one of the best nursing experiences that she's had in her career. She really felt like she was making a difference here for physicians, patients, everybody worked together. So that was great. And one thing I'm going to tell you, that there is a lot of false information out there. Patients want to listen to whatever they want to. I'll tell you, the hospitals that I'm at, patients have an abundance of information. I mean, each of our patients' room have Google tablets. True story, had a patient who had COVID-19. He was really sick. And that was at the same time when we decided we're not going to use hydroxychloroquine and azithromycin just because of what the FDA announced. I walk in the room, the gentleman is doing fairly well. I said, look, if you don't get better in the next 24 hours, I'm going to give you this new drug called remdesivir, which we have on hand. Literally, he was so upset with me. He goes, why are you not giving me hydroxychloroquine and azithromycin? The commander-in-chief recommends it. The White House recommends it. And you, of all folks, the ID expert, does not recommend that. He was so upset. I thought he was going to call the Texas Medical Board on me, whatever. But long story short, we had him on the Decadron, the remdesivir. He got better and went home. What does he do 2 weeks later? He files a complaint with our hospital patient advocate. First thing.
Wow.
And, I'm like, holy cow, you walked out of here alive. We thought you were going to be on the ventilator. We thought we were going to have you on a rotaprone bed, but you came out of here alive. Still went and complained. And his main complaint was, one, that ID physician, Dr. Bayani, was a real asshole. Pardon my language. Why? Not because I gave him remdesivir and he got better. It's because I asked for hydroxychloroquine and azithromycin. He did not do that. He gave me some experimental drug. Not only that, he's like, forget it. I'm not going to even complain to you guys. I'm taking my complaint to my senator, my congressman. I'm going to make sure it gets to Washington, D.C. because you guys are behind a curve on treatment. And of course, a few days later, the wife called us and said her husband has been acting delusional. Pardon him, but we are very grateful as a family that you saved him. So these are the people that are out there. And I think when you have so much false information and the wrong people speaking, it creates such a bad judgment call that even here as physicians, we're working our hardest to save people. And, at that point, it didn't hurt my feelings. I said, whatever. I did my part. The patient I took care of walked out of here alive. If he wants to go complain, that's his prerogative. My job is to make sure you get better and get out of my hospital alive.
Alive. Yep, that's all you can do.
Thank you, Nikhil.
Sure.
And Nick Peluso, you want to go next?
Yeah, sure. I mean, I as a COVID-19 pandemic actor, I've seen plenty of people, with misinformation, bringing things in to the hospital. Family members demanding certain treatments, and I've been called a deep state government operative. All sorts of crap like that. I think everything that everybody else has gone through who's treating this. It's a very weird time. I've never seen anything like it. I've never seen people not trust physicians like this. I mean, I think it's been going on for a while in terms of less trust, but I think right now it's just an outright, we don't know anything. That's kind of what I've experienced more so on social media than I have in the hospital. A lot of my patients can't talk, but their family members can't. So they do bring in some stuff like that. And we try to just sit down and explain to them why it's not effective and why it's not our protocol. I think we've done a good job of kind of handling that. But in terms of anything that is linking you to a YouTube video, I think is probably not the way to go. And if it's showing that it was taken down, it's probably not Facebook silencing you because of censorship. It's probably because it's complete misinformation. So I just kind of tell people, just listen to physicians. They're the people who are directing this. That's about all I can say. It's been extremely frustrating. That's the other defeating part of it. It's treating the illness is the defeating part. Also, dealing with public and misinformation has been extremely defeating too. And I don't even have to deal with what ID has to deal with. So it's multifaceted and it's very frustrating.
Thanks for that, Nick. And Mona, any final words for the general public?
I think kind of like with all of my colleagues, we all realize that it's sort of been a whirlwind of everything, from the emotions to the guidelines to just the case numbers to, okay, what's next, like reopenings, etc. For New York City right now, we're bracing for our kids. Actually, kids have started going back to school, and so bracing for fall. It's starting to get cool at night, Mm-hmm. So I guess the only advice that I can give that is, just be kind to yourself. I think like Nikhil said, there might be some genetics to it, but a lot of it is just the state of your body. So if you're healthy, you're eating healthy, you're exercising, you're taking your vitamin C and zinc at home. Maybe, I think at this point, especially in New York City, most of us have been exposed. And if you weren't already exposed, you're going to get exposed at some point. So that's just by virtue of like the proximity of New York City. And then with the kids going back to school, those cases are definitely going to go up. So the only advice I would give, protect yourself, protect your family. I mean, all we know right now is wash your hands, wear your mask. I don't know. I believe in it because I think I see the effect that it's had for New York City we stayed home, we wore our masks consistently, and now we're able to be outside and enjoy, the last few days of summer. We wear our masks as we walk to the restaurant, sit down, and if somebody gets up and walks around in the restaurant without their mask on, we all look at that person crazy, and they know that something's missing and they put their mask on. So, some people think it's being sheep to follow these guidelines. I don't, because I've seen what happens when we don't, when we just kind of do whatever we want to do. If literally the whole country just followed the guidelines for 3 weeks, just 3 weeks, the whole country, we might be in better shape than we really are. It's really embarrassing that, the biggest country and the strongest country in the world is doing so badly. So let's just do our part. Keep safe, guys. There's not much else. Wash your hands, wear your mask, and listen to your doctors.
Yep. I think that's about it. Thank you, guys. I think the big, like Mona said, wear masks, practice the social distancing, and protect yourself and protect your neighbors. Protect your friends, your neighbors, your family. We're all in this together. Thank you, guys. It was a very good show today, where you guys were able to share with us your insights and your experience. This show is going to be available on YouTube later tonight, and I will send it to you guys. You guys can share it with your friends, and in your social media page, and also we'll put in our social media page too, in the Medical Journal Club. Yeah. For the doctors that's following us, we are the Medical Journal Club, and every 2 weeks we have lectures, and today we decided to do something different to listen to doctors and to talk to each other. I think one of the big part of Medical Journal Club, that's what we're trying to do. We're trying to make doctors talk more with each other, because there's a lot we can learn from each other.
Absolutely.
Absolutely.
Totally.
Thank you, guys.
Thank you, guys.
Yeah.
It was real. Yeah.
Take care.
All right. Thank you.
Thank you. Have a good evening.
And you too.
Thank you very much.
Thank you.